Today, I have with me Dr. Nathan Painter. He is a clinical professor of pharmacy at the University of California, San Diego Skaggs School of Pharmacy. Even though Nathan and I both worked at UC San Diego, it wasn't until I attended a meeting at the Prescription Drug Abuse Task Force in San Diego that our paths actually crossed. Nathan is very involved with that group, and they do a lot of work around drug abuse. Community education, education for health professionals, different initiatives that work toward decreasing the harms associated with the misuse of prescription drugs. And they do that in San Diego County. For those of you listening in other counties or other states, I suggest that you go take a look at their website and see some of the things that they've worked on, because they're doing some great things. So welcome, Nathan.
Thank you very much. Thanks for having me.
Let's start off by having you give us a bit of an inside look at the San Diego Prescription Drug Abuse Task Force and some of their past accomplishments, things that you feel kind of express what the task force is all about.
Yeah, the task force has been around for, about almost 10 years now, it feels like, and has really been able to develop some things that have that we're pretty proud of. I think the first major accomplishment that happened that really kind of put us, on the proverbial map was one of the leaders of the executive committee and the medical community, who's a ER physician at one of our local hospitals, developed the protocols and kind of these guidelines for how to prescribe opioids in the emergency department, and really focusing on limiting quantities, doing better assessments, and screening people for abuse potential. And it pretty slowly but surely spread to the California Emergency Department Society, which I don't remember the name of it right now, and at pretty much every hospital in San Diego County, and then many hospitals throughout the rest of the state. And so many adopted the guidelines. We're posting them. We're giving them to the providers and the staff to give to patients, so that everybody knew that this was the policy. This is how we were going to do it. And it wasn't just about limiting opioids and limiting controlled substances. It's really implementing best practices of what we know when it comes to emergency department and pain management and abuse potential. And really highlighting that, if the patient is in pain, long-term needs to be treated by their primary care or their pain specialist. The emergency department is not into pain management. It's there to treat emergencies. And that really just helped us set that guideline. And 5, 6, 7 years ago, and that guidelines are still strong and still being adopted and still being utilized today. And many other states, with that example, have implemented similar policies, either through legislation or regulation, in their own states. So that's probably one of the big things that we've been proud of. I think the other thing is, like I said, we've been, I think it was 2003. I always forget the year that we actually started, but again, about 10 years ago, the group was started, and with, I think, the emergency department opioid prescribing guidelines coming out, it really highlighted that these type of groups were needed throughout the state. And there was some federal money involved, and the state utilized some of that money and some state money to as incentive and startup funds for different counties throughout the state to develop similar prescription drug abuse task force, whatever they wanted to call it, but some group to address the issues when it comes to prescription drug abuse, when controlled substances and whatever, and use San Diego kind of as the benchmark. San Diego was included in a lot of the calls to, for people asking questions about what does this look like? What do you mean? How do we form this? And in fact, San Diego was not allowed to receive some of the grant because they were, at least the initial grant, because we were already so well established and, again, being used as the template for what they were trying to spread across the state. So I think those are probably the two big things. There's lots of little things that we're very proud of. I will say one more thing. The other big thing is is educating our high school youth about the dangers of pain medications and their parents, which ultimately led to a law in the state that requires notification to parents and athletes in high schools about the dangers of pain medications and specifically opioids related to sports, because kids get injured, kids get hurt, they have to take can sometimes have to take pain medications, and really dissuading the kids and the parents from just going straight to opioids, but using other things for their pain management in high school. And again, that actually ended up spreading to a DEA national campaign, and that started right here in San Diego.
Is that law, who has to notify them? Is it the physicians when they come for treatment, or
the sports, the teams? So the schools have to notify. There are certain other organizations, I don't remember all the names, that have to notify. So basically, as people are signing up, once they make a team, there has to be some notification before the sport actually starts. They have to get a fairly standard piece of paper that says, here's the risks of using these medications, and therefore short term, and use other methods for adjusting pain, those kind of things.
That's great. So welcome to the team. In case you get hurt, you be careful. You don't want to take these things. That's pretty cool.
And it's certainly, at that age, it's certainly for the parents to
Sure.
have them ask questions, and to have them bring up these issues with their physician in case it's not been brought up before.
Yeah, because it's not something, you're going to trust the physician, and of course they have an injury and they're in a lot of pain, so it makes perfect sense. Why would you even question, going to the opioids? That's what your prescription is for, right?
Right.
So that's great. That's cool. And that sheet that you said that you made for the ED, what to expect for patients, what to expect when they come to the emergency room. I worked in an independent hospital up in North County, San Diego, and we used that. I didn't realize that they were using it. And being new to the hospital and kind of getting the lay in the land, I remember very distinctly at one point, one of the ER nurses, yeah, we have that piece of paper. Where are those papers? We need to give those out. We used to give those out all the time. Where are they? And so they kind of got them back out and started distributing them again. So they definitely were distributed throughout the county.
Yeah.
All right. So how does the task force decide what initiatives they're going to work on?
That's a great question. I think that's what one of the great successes of this task force is. Once a year, we break up into different groups, and depending on what's going on, the groups are slightly different, but usually comprise of healthcare, law enforcement, prevention, and treatment. And basically, these four, whoever identifies, you self-identify as what group you belong to, you gather together. There's a facilitator that the task force provides, and we get down and you talk about what you want the initiatives to be for the next year. What trends are you seeing? What issues are you having in your sector? And we get together. We have these small groups, and then once the individual groups have had a chance to discuss and kind of flesh out some high priorities for that year, we meet as the bigger group and we go over them, and we try to kind of nail down kind of the top 3 to 5 initiatives that we're going to try to address that year. And so it's a great process. That's where different ideas have come from that we've pursued, that have turned into major events and major things that have been published or put out from the task force.
Right, great. And that brings up a good point too. You have all of those groups represented. You do have law enforcement and prevention. I guess that'd be what, pharmacists, physicians, perhaps.
Yeah.
And then you've got your rehab facility people that represent, and you've got all different, types of people. It's not just pharmacists.
Exactly. Again, prevention specialists who are, in schools, and then there's treatment folks, and there's people in recovery. There's law enforcement, like you said, from every sector: police, sheriff, DEA. We've had other representatives from other folks every once in a while. We have folks from the military bases and from the Veterans Administration. I'm pretty sure all the major hospitals we have somebody represented, and many of the other smaller hospitals. again, the huge treatment facilities that have received federal and state funds to do, these incredible programs to try to, address treatment in different ways. Youth advocates, patient advocates, parents of people who have been, have died or been severely affected by their overdose and prescription drug abuse. I mean, you name it, it seems like if they're touched by this epidemic, then they're pretty much a member of the task force, which has been one of our successes from the beginning, is that it truly has been a collaborative effort, and the door's open, and anybody who's interested can participate. There's no, where do you belong, or who are you, or why are you doing this? And I've heard, unfortunately, just like any other kind of group of people, not everybody plays well together in the sandbox, and I think a lot of other regions have not necessarily had the same success that we have. But I think that we were set up from the beginning for success because of that collaboration between the different sectors.
Definitely. They all have something to bring to the table. I mean, it's a completely different perspective that you don't even realize is there until you hear from somebody else. So
Yeah,
I think that's
exactly.
fantastic. What are you working on right now?
So, with the fentanyl crisis, we've really had to take, it's not really a left turn, but, the whole country has done a pretty decent job with prescription drug abuse, like real prescription drug abuse, right? So the prescribing is down. The number of pills out on the street are significantly down. So the healthcare industry has actually done a pretty good job of addressing the crisis. There's plenty of work to do, but it has made strides. So the transition a few years ago to other stuff, right? So unfortunately, it seems like people are going to use things, and so prescription drugs weren't as accessible, so they switched to other things. So one of those things is fentanyl, where it's not the prescription or the pharmaceutical grade fentanyl. This is illicitly made fentanyl in labs and warehouses. A lot of it is coming up from Mexico. A lot of it's coming from China and India. But it's, right now it's being made to look like prescriptions. And so if you buy like an OxyContin or hydrocodone on the street, it's probably made from fentanyl now. Because we have done such a good job of controlling the number of pills out on the street when it comes to real prescriptions, now they're being made illicitly, and so people are getting them from friends, they're buying them from people, and they think they're getting one thing when they're actually getting fentanyl. And the big thing about fentanyl, is it's, as you know, it's just really, really potent. So even a small amount, if you've never taken an opioid like morphine or oxycodone or whatever, a small amount can kill you. And because it's being made in warehouses and garages and backyards, there's, one pill can have 0 fentanyl, another pill can have 10 milligrams, which can kill 20 people, so it's just, it's just all over the place. And so that has leaned a little bit more towards prevention and law enforcement, just because of that nature. It's very, as a pharmacist or as a physician, we can continue to advocate that people don't take things that they don't know where it came from. But we're not out on the street trying to stop that from happening. So we've actually kind of made that shift, and a little bit more heavy on the law enforcement, and not the arresting piece of it, but just where is it coming from, trying to stop that pipeline, trying to get the word out to the San Diegans that, hey, you're probably not getting what you think you're getting. It's showing up in other illicit drugs. It's showing up in cocaine. It's showing up in methamphetamine. It's showing up in all these other things that people, think they're getting. They think they're buying their drug of choice, and indeed it's actually not. It's fentanyl. And so, because of that, because of how it's made, we end up having these pockets of deaths, where that supply, it reaches a couple of friends, they take it all together, and 3 or 4 of them end up dying. And so that happens all too frequently, and which is a direct result of the fentanyl issue. And again, it shows up in other things too. Every once in a while, deaths will happen. They'll go in and try to investigate, and they'll realize, oh, it wasn't actually this, it was fentanyl that killed this person. So
Yeah, I guess I would imagine the message is maybe different for the recreational user, like, don't do it,
It really,
versus
yeah.
the one who is addicted and, they need to get their stuff somewhere. So that we have to address the addiction then, right? To keep
Yes,
them.
and absolutely, and has been that's been an underlying thing for the last couple of years is really trying to get access to treatment up, people aware of treatment to begin with. I mean, there's still many people who really don't even know that it exists, or how to access it. How do you get into it? How can you just walk into a treatment center? What treatment centers are the best, right? So developing best practices, and knowing where to go and who offers the services that have the research and the data to support um, um, their even existing. Because unfortunately, there are plenty of, just like anything, there's things out there that
Right.
are just taking advantage of people. But most of it is is pretty solid, and they have the evidence and what the research to back up the methods that they use.
Sure, sure. Okay. Tell us a little bit about academic detailing. Does the task force do anything around that?
Yeah, so actually, almost a year ago now, the San Diego County Medical Society received a grant to further increase provider, physician, pharmacist, and nurse practitioner and PA. So anybody who can prescribe. Um, Again, kind of reinforcing the opioids, benzodiazepines, and the fentanyl issue and medical marijuana, and trying to address that kind of as a package to anybody who can prescribe medications or who are involved in prescription medications. And again, kind of re-upping the education, because there's been a while since anybody's really focused on, at least through the task force, anybody's really done a major push for educating physicians. Because again, even though we've done a good job over the last few years, there's still plenty of room, there's still plenty of issues that we need to try to address. And so this is kind of another effort, in addition to developing this kind of curriculum that is just to educate the broad community. Academic detailing is going to be brought on board, hasn't started yet, to do more one-on-one sessions with physicians who might either have questions or who have been identified through various channels as maybe needing a little bit more education. And so it's a one-on-one approach. It's called academic detailing, right, because it's kind of a specific approach. But I think the core of it is it's a one-on-one sit down, trying to figure out where the physician is, what the education that can be provided to help change, and it's all about change. So we do a lot of behavioral change with patients. What is their motivation for certain things? What can we say to them? What information can we provide to them to change their behavior? This is kind of the same thing. How do we get them to, in this case, prescribe more appropriately, like follow the guidelines? Do they even know what the guidelines are for prescribing certain medications, what things to avoid, and what they should be assessing in their patients to find out if what they're doing is safe and effective.
And how do you, is it, if it's a facility that's in your task force and they get the training on that, then they go back and they do it? Or do you guys focus on, for example, I remember a few years ago looking at cures when I was looking for a patient prescribing thing, and saw a physician that, had what we call the holy trinity, right? It's benzos, the opioid, the soma. It's like, oh my
Yeah.
gosh, to the same patient. So he would be one you would want to target. But do you get names that way and go and do the detailing? Or is it more the facility and the person who's kind of working in that facility takes that to their people?
I actually haven't learned all those details yet, but my understanding is that through our partners, through the San Diego Medical Society, they kind of already have partners. So it probably will be more the institution asking us to come in and maybe to identify, and not to target certain physicians, but maybe a certain group of physicians, so that it doesn't look like the people are being
Yeah,
penalized, or
right.
singled out, that kind of thing. So I'm still learning more about that every day. We have just finished the curriculum, and so taking the next step with the academic detailing is going to be coming up in the next probably more like 3 to 6 months. So it's not quite ready for prime time. We still have to be trained, for, even though we developed the curriculum, we've been doing this for years, we still have to be trained on the process, because again, it is kind of a process to what the academic detailing is.
Sure, that makes sense. Okay. And are you doing anything around safe disposal?
Yeah, so safe disposal's been a major issue for this last couple of years. San Diego's done a survey every 2 years, just kind of gauging in the community what they know, what they're doing for as far as drug disposal, and what we and where they're hearing about it. And so the good news is some people are doing the right thing. The bad news is there's still a lot of people that are improperly disposing of medications or aren't doing anything. And so we continue to try to get the word out. Media is a huge way that people have said that they've heard about how to do drug disposal, and that usually surrounds the semi-annual take back day that the DEA sponsors. That's usually in April and October of every year. Um, but just getting the word out of the year-round takebacks is there's places all over San Diego and all over California, in either pharmacies or county administration type buildings, sheriff, police departments, all these different sources of places where you can take unused medications back to get them, out of the hand, just get them out of the way. Um, because we live in an area where there's such good access, it is not recommended to throw away or to flush down the toilet any medications whatsoever. It's always recommended to use these take back disposal methods because it's just better for the environment and keeps things, out of the water supply, out of the sewer, out of seeping into the ground. And so people hear about flushing and throwing down the trash, and that's really, honestly, that's really just reserved for places where there are no options. And so the DEA has a website. If you Google DEA drug take back, it will take you to a website where you can put in your zip code and find the closest either year-round take back site or one of the DEA take back days in October and April, and it tell you exactly where you take your medications to dispose of them.
And I don't know the answer to this question. With them being a federal agency, is that the same? Do they have those take back days? Do you know, outside of California, like in every state, same day everywhere?
Yes, so that became
Okay.
a national, and I guess I didn't mention this earlier, but the DEA takebacks also started in San Diego.
Oh my gosh.
So it
Okay.
actually started in San Diego with the who at the time was one of the chairs, who was the chair of the Prescription Drug Abuse Task
Mhm,
Force, and he was a DEA agent.
mhm.
And it was kind of his idea. He started it, and DEA heard about it and said, "Let's do this." And so it became a national event, and then became a twice a year event. And it is all over the country.
Interesting. Was that Tom?
Tom Lennox, yeah.
Yeah, yeah.
Yeah,
Okay. All right. Interesting. I didn't realize that. Okay,
yep,
that's pretty cool.
yeah.
For someone listening out there that may not be, they don't have anything like this in their county and they'd like to start something, do you have any words of wisdom for them and any suggestions on how to maybe get started?
I think there's many ways to do this. I think one would be go to your county's health and human services, or whatever you call it, and find out if there's anything that already exists that's like this, even if it's a small committee that's at the county, or if they have heard of other members that might be interested. Another way to go would be, through different local health associations. So your local physicians group, your local pharmacist group, your local, whatever group, and find out if there's interest within those communities. And then so many different areas have, again, prevention specialists that are already meeting. So find out if they have a kind of a gathering or a group of people, and get involved with what they're doing as far as educating, young people, and preventing prescription drug abuse, and really just drugs of abuse in general. Um, and I think finally, there's an overdose awareness day. There's a prescription drug abuse awareness type day in many different places. And so utilizing that and going to your local politicians, board of supervisors, city council, and specifically asking them, to do something about it. Create a group, create a committee, create a task force that can be supported by the local government, to do some of these things to get people together. I don't, legislation isn't necessarily always the answer. I think many people know that. It really should be a grassroots, but sometimes if you just get a little extra support behind you,
Sure.
then that might get the ball rolling.
Sure. Great. Okay. All of that sounds fantastic. Well, thank you very much, Nathan, for spending the time with me today.
Thank you very much.
All right.